Hello dear friends, good evening. The first question. An open fracture with extensive soft tissue loss more than 10 centimeters. Okay, extensive soft tissue loss more than 10 centimeters. This is the word, extensive soft tissue loss more than 10 centimeters. Severe contamination, adequate vascularity is classified under what Gustilo-Anderson's type? We know Gustilo-Anderson type 1, type 2, type 3A, type 3B, type 3C. See, extensive soft tissue loss is there. This is the word. Severe loss is there. Extensive soft tissue loss means that needs skin grafting. So, the answer should be type 3B. It is the wound size. Let us see. We are going to discuss the Gustilo-Anderson. So, for this question, the best answer among the four choice is type 3B. This should be the right answer. This should be the right answer. Yes, I will give the explanation. You see here, Gustilo-Anderson's type 1. This is the question, several times repeated question in INI-CET, NEET PG, most of the entrances. Type 1, wound less than 1 centimeter. Wound less than 1 centimeter. There is no devitalization of the soft tissue. Gustilo-Anderson. Type 2, wound more than 1 centimeter, less than 10 centimeter. There is no devitalization of soft tissue. Soft tissue loss is not there. So in type 1 and type 2. Type 3, wound more than 10 centimeters, there is some soft tissue devitalization. If it is type 3A, it is more than 10 centimeter. There is some soft tissue devitalization, but you can close with the same skin. No need of skin grafting. So that is type 3A. Type 3B, extensive soft tissue loss. Bone is exposed and you cannot close with the same skin. It needs definitely a skin grafting. It needs a skin grafting. So this is what the question they had framed. Type 3C is a very dangerous condition. It's an orthopedic emergency that is associated with vascular or arterial injury. That is type 3C. Okay. So whenever in the history, whenever in the clinical scenario question, they use the word arterial associated with arterial injury, directly it will go to type 3C. Once artery is injured, the skin wound size doesn't matter. That's the question. This is a very important thing. Gustilo-Anderson's. Please register this in your mind. Okay. So shall we move on to the next question? You see here, a 45-year-old woman with a history of alcohol use disorder. Okay. So she's consuming alcohol for a long time. Presents with hip pain. So this itself will give the diagnosis. Chronic consumption of alcohol, hip pain. The diagnosis that should come to our mind is avascular necrosis. Okay. So in orthopedics, a golden teaching, chronic smoking notoriously to cause non-union, chronic alcohol consumption, chronic steroid intake notoriously predisposes avascular necrosis. So an MRI of the hip reveals smooth linear geographic signal abnormality, that is concave. This is the word, concave to the articular surface. There is central fat signal and both low and high signal demarcation. What condition is most likely indicated in the MRI? When you see this MRI, okay, here you are able to see a concave lesion, okay, like this, a concave lesion, right? So this directly it says this is avascular necrosis. So what is this name of this sign? This is called crescent sign. This is called crescent sign, right? This is called crescent sign. Good. See, the X-ray will not turn positive before 3 months after onset of ischemia. Okay, X-ray will not appear before 3 months after onset of the ischemia. So minimum 3 months should have crossed, then only X-ray will show you. Increased bone density is a sure sign of avascular necrosis. Crescent sign. Thin tangential fracture line just below the articular surface. you see here, this is your acetabulum, this is head of the femur. When you see here, I am able to see a crescent shaped shadow. I will erase everything, you zoom and see. This is the classical crescent sign. So whenever you see a crescent sign, that is an radiologically sure sign of avascular necrosis, but that will take 3 months. Then which is the earliest investigation? You may think radioscintigraphy, that is also not right. It is used, that's all. That is used, not very specific. Aptly is using the word, it is used. CT scan can be used, that is the word. MRI, this is the word written in the textbook. This is the most reliable way of diagnosing marrow changes and bone ischemia at a comparatively earlier stage. Comparatively earlier stage. So this is a sure sign. Okay, this is MRI, is a sure investigation, best investigation. Okay, intramedullary pressure measurement definitely will give you the normal pressure. Intramedullary pressure is 10 to 20 millimeters of mercury, but it's an invasive investigation, so usually we won't poke a needle. Okay, so this is the best investigation when you suspect avascular necrosis. Whenever a question avascular necrosis comes in our exam, they are asking for a best investigation, we should go for MRI. Okay, yes, this is the staging, Fickett and Orlet staging of avascular necrosis. Stage 1, no radiographic abnormality, absolutely no radiographic abnormality. MRI may show changes, high intramedullary pressure, diagnosis confirmed only by biopsy. So stage 1, X-ray will not show anything, MRI may show, it's not sure. Okay, so it's only clinical suspicion. Confirmation is only by biopsy. Normally we won't do. Already you are suspecting some avascular necrosis in the bone. When you want to do a biopsy, you have to poke with a needle. Usually we won't do. Stage 2, very painful, early radiographic changes. Bone outline is normal. Okay, bone outline is normal. Stage 3, clear-cut radiographic features, and the clear-cut radiographic feature is your crescent sign. Abnormal bone outline. The bone outline is altered. For example, normally here, the head of the femur, you take head of the femur, it will be round, globular in shape. This is normal. This is normal. Abnormal bony outline means this head may become flattened like this. Okay, this may become flattened like this. That's called a mushroom shaped head. So that may be flattened. Shape of the head is altered. When the shape of the head is altered, when the patient continues to walk, this is rubbing against the acetabulum, and that will predispose secondary osteoarthritis. So that is stage 4. Stage 4, collapse of articular cartilage and secondary OA. So stage 1, no radiographic changes, clinical suspicion, confirmation only by biopsy. In biopsy, I will tell you one extra point. What is the change that is shown in biopsy? Outline, you know very well, bone marrow has bone marrow fat. The outline of the fat cells of the bone marrow is altered. That is the earliest biopsy change of avascular necrosis. Outline of the fat globules in the bone marrow is altered. Okay, so that's a histopathological finding. But normally we will never try a biopsy for this avascular necrosis. So this is stage 1. Stage 2, very painful. Clear-cut clinical features are there. Early radiographic changes like increased bone density or sometimes a crescent sign may be seen. But outline is totally, it is normal. The globular thing is normal. But even to show this, it is taking 3 months. This is the thing. So X-ray is a good investigation, but a late investigation. Stage 3, the clear-cut radiographic features like increased bone density, your crescent sign, everything will be there, but bone outline is altered. That is stage 3. Stage 4 is secondary osteoarthritis. So this is about avascular necrosis, very important. Coming to the third question, a 3-year-old child is brought to the clinic with concern about foot abnormalities. You see the foot. I am able to see here, this metatarsal is normal, but the hallux is going inward. This is called, what is that? Yes, hallux valgus. It is called hallux valgus, right? The great toe will turn inwards. That's called hallux valgus. And an anteroposterior radiograph of the feet is taken as shown below. The child exhibits episodic painful swelling in the shoulders and neck leading to difficulty in movement. What is the most likely diagnosis? Okay, think and answer. This is a typical INI-CET type of question. The diagnosis is Fibrodysplasia ossificans progressiva. Diagnosis is Fibrodysplasia ossificans progressiva, right? So that is the diagnosis. This is, you see, Myositis ossificans is divided into two main types. One is Myositis ossificans traumatica, another is Myositis ossificans progressiva. Myositis ossificans traumatica is a, what I can say, it's a traumatic condition, acquired condition. Myositis ossificans progressiva is a congenital condition. It is a congenital condition. So this Myositis ossificans progressiva is a congenital condition. You should know about certain things. It is a congenital, common in age presentation, you see 5 to 15 years. Myositis ossificans traumatica, anytime when they go to traditional bone setter, that is going to be a problem. So this is 5 to 15 years. It usually starts in the region of trapezius and latissimus dorsi. Finally, it will involve all the joints including costochondral and temporomandibular joint. Costochondral and temporomandibular joint. Okay, it can involve diaphragm, it can involve extraocular muscles, cardiac muscle, smooth muscle. You see, the thing is, common association is microdactyl. There is short fingers, clippal field syndrome, short neck, congenital fusion of all the cervical vertebrae is called clippal field syndrome, hallux valgus. This is very important. You see here, this is the classical hallux valgus. Okay, so these are the associations. These are asked questions. Patient usually dies due to intercurrent infection. Okay, never do biopsy. When you do biopsy, that will worsen the situation. Treatment, there is no curative treatment. Bisphosphonates are tried. After excision of bony bars are tried. Okay. This is a next question. A 30-year-old woman presents with pain and swelling in her right elbow following a minor fall. She received a deep tissue massage shortly after the injury. Examination reveals tenderness and limited motion of the elbow. The lateral radiograph of the right elbow is shown. What is the most likely diagnosis? Okay, what is the most likely diagnosis? Most likely diagnosis is osteogenic sarcoma, aggressive fibromatosis, osteochondritis, myositis ossificans, traumatica. Okay, you see here, you see this elbow, elbow joint is involved. I am able to see a fluffy mass around the elbow. Okay, this is a classical X-ray of myositis ossificans traumatica. This is a classical X-ray of myositis ossificans traumatica. Okay, so you see here, myositis ossificans traumatica is an ossification happening in inflammatory muscle around the joint. Right, the most common cause is ill-advised massage due to a traditional bone setter. So, myositis ossificans traumatica is otherwise called ectopic ossification or ossification happening in unwanted sites. Normally, ossification will happen enchondrally in a long bone, membranously in a flat bone. Okay, so here what happens? No, ossification happens in 4 important structures outside the normal site. One, it is what are the 4 structures that are dual? Number 1, it is muscle. Okay, second is tendon, muscle tendon. Third is fascia. Fourth is periosteum. These are the 4 structures. These are the 4 areas where myositis is happening, right? And the most common cause, I told you, it is ill-advised massage. Ill-advised massage. So this is the most common cause. Now, hematoma in the muscle is the underlying cause. Most common site of myositis ossificans traumatica is elbow joint, that is lower end of brachialis muscle. This was an asked question. That is why whenever you see this thing and fluffy mass, a calcified mass in the elbow joint with history of trauma, went to native treatment, the diagnosis should be myositis ossificans traumatica. That's the most common site. It can happen in hip, it can happen in ankle, and it can happen in knee. Okay, in knee, this is called Pellegrini-Steedas disease. When myositis happens in the ankle, that is called footballer's ankle. This is called footballer's ankle. Okay, yes. And you see here, X-ray, active phase shows fluffy mass, mature phase shows trabeculated well-defined mass. Differential diagnosis for myositis ossificans, one should not forget, several times repeated question. The differential diagnosis is osteogenic sarcoma. Osteogenic sarcoma. Okay, osteogenic sarcoma, right? So you see, osteogenic sarcoma is the most important differential diagnosis. Only way to differentiate myositis ossificans from osteogenic sarcoma is not by X-ray or clinical presentation. That may cheat, because X-ray in myositis will show you periosteal elevation. In osteogenic sarcoma also will show you periosteal elevation. So the only way to confirm the diagnosis is by biopsy. There is no other go. If the history is not clear, okay, so both the condition clinically and radiologically will look the same. So confirmation by a biopsy will show you if it is myositis ossificans. The classical histopathological appearance is called Ackermann zones phenomena. Ackermann zones phenomena. When you see this histopathology, this is divided, you see here, up to this is one zone, up to this is another zone, this is the third zone, this is the third zone, this is the second zone, this is the first zone. So innermost zone is this first zone is called cellular zone, middle zone is called zone, the second zone is called zone of fibroelastic tissue, the outermost zone is zone of mature well-oriented bone, and that is the third zone, mature well-oriented bone. So this is the biopsy finding, and this is called Ackermann zones phenomena. Ackermann zones, once Ackermann zones phenomena is there, the diagnosis myositis ossificans is confirmed. It is definitely, it is not osteogenic sarcoma, because in osteogenic sarcoma you will see a different picture, spider cells, and totally it's a different picture. Coming to treatment, prophylaxis with indomethacin 75 mg BD for 3 weeks post trauma. A trauma has happened, unknowingly patient had gone for a native treatment. What to do? If he comes immediately, don't massage, give rest, give a cuff and collar sling to the arm, then you start on 75 mg indomethacin BD for 3 weeks. Okay, and better avoid bisphosphonates, because in some cases this is triggering myositis ossificans. Better avoid. Don't use your bisphosphonates that may trigger myositis ossificans. Low dose irradiation is indicated in foreign books 72 hours post injury. Definitive management, once a myositis mass is formed, allow the mass to mature, that it will take 6 weeks. After that, complete surgical excision of the mass. Okay, it is the treatment of choice. This is the treatment of choice. Complete excision of the myositis mass is the treatment of choice. Okay, now coming to question number 5. A 10-year-old schoolboy was playing on monkey bars during recess when he suddenly slipped and fell onto his outstretched hand. He immediately felt intense pain in his wrist. On examination, there is significant swelling and tenderness over the wrist. An X-ray of the wrist reveals specific finding indicative of fracture. Based on the history, clinical feature and X-ray finding, what is the most likely diagnosis? The age group is 10 years. History of fall is there. The child has developed some fracture. X-ray is showing. When you see this X-ray, it's showing a fracture pattern. This area, a bulge like thing. This is the fracture line. That is the fracture line. I will erase, just you see, that is a fracture line. Okay. So what is this fracture called? This fracture is called torus fracture. This fracture is called torus fracture, right? You see, torus fracture is otherwise called buckling fracture because you see here, this periosteum is buckled. This periosteum is buckled. Okay, so this is called torus fracture. It's called buckling fracture. This is the most common fracture in the children. Commonest site is forearm bones as the child falls on outstretched hand. Here the cortex bends and actually doesn't break. Now, coming to the sixth question, a newly joined military recruit person with continuous pain in the right lower limb, okay, during morning drill. So he is a military person. That means he have to do a march past. That is giving us the clue. On physical examination, there is localized tenderness over the mid shaft of the second metatarsal. Mid shaft of the second metatarsal. X-ray imaging is provided. What is the most appropriate next step in management of the patient? Rest and activity modification, surgical fixation, application, immediate return to physical activity. What is the diagnosis? This is called march fracture. This is called march fracture. And the best thing for a march fracture is, Shivani, the best thing for march fracture is give rest and activity modification. Give rest and activity modification. Okay. So how much rest you should give? 14 days. You see this march fracture is otherwise called fatigue fracture. This is otherwise called fatigue fracture. This occurs due to repeated minor trauma or stresses. Here the bone is normal. So this is commonly happens in army personnels and those who stand for a long time. Right. So in operation theaters, you want, yes, rest for 14 days. You are right. You see here, you won't believe, one of my theater staff nurses very recently, okay, so she is a retired staff from government service. That means she has exceeded 60 years. In theater, it's a very efficient theater staff in orthopedics. She used to stand the whole day. One day she complained of severe pain in the right foot. No history of trauma. 2-3 days she was complaining the same thing. Okay, when we just took an X-ray and I saw neck of the second metatarsal, there is a hairline fracture. No history of trauma. Because the only thing, she's standing for a very long time. That's why this picture. So this fracture is called a march fracture, otherwise called a fatigue fracture. Right? The best treatment for that, the most common site is second metatarsal neck, classical site. Then it can happen in proximal tibia, fibula, pubic rami. Don't forget. This is a very rare site, but you should not forget pubic rami. And the best treatment for that is bed rest and if needed, analgesics, 14 days. Why? See, the point I want to insist, for this fracture, there is no need of POP. For this fracture, there is no need of POP. Just bed rest, NSAID. That is the bookish treatment. That is the thing you should write in your exams. Now, a 35-year-old man presents following high-speed motor vehicle accident. He complains of severe pain, swelling in both lower limbs. Upon physical examination, the affected area has significant bruising, deformity and tenderness. An X-ray is performed. What type of fracture is most likely in this X-ray? This X-ray gives a very clear fracture. What type of fracture is this? The X-ray shows. This is a classical comminuted fracture. This is a classical comminuted fracture. Okay. So you see here, comminuted fracture, here there is more than 2 fracture fragments. Whenever there is more than 2 fracture fragments, that is called a comminuted fracture. It is caused by high energy impact. This type of fracture may have a butterfly fragment. You see, more than 2 pieces. More than 2 fragments. You see, this is caused by high energy impact and this may show a butterfly fragment. Butterfly fragment means a separate fragment. Okay? Yes. An elderly patient, we'll go to the 8th question. Elderly patient with hip pain after fall has a normal X-ray but holds the leg shortened and externally rotated. Okay? You see, elderly, the leg is shortened and externally rotated. Next best diagnostic step. What is the diagnosis? Elderly patient, history of trauma, the leg has shortened and it's externally rotated. The diagnosis is very clear. It is neck of femur fracture. This is neck of femur fracture. So the question asked is the next best diagnostic step. This is MRI. The next best thing is MRI of the hip. Okay. Yes, because the complication of fracture neck of femur in an elderly is avascular necrosis with non-union. Avascular necrosis with non-union. Okay. So the next best investigation is MRI. And just now we have completed the topic avascular necrosis. Best investigation when you suspect AVN, avascular necrosis is MRI. Earliest way, best way to diagnose avascular necrosis is MRI. So MRI won't miss anything. So that's the best investigation. Coming to the 9th question. A 12-year-old boy presents to the emergency department with fever, localized pain and swelling over the proximal tibia. Okay, a 12-year-old boy presents to the emergency department, fever, localized pain, swelling over his proximal tibia. Blood test reveals elevated white blood cell count and inflammatory markers. Okay, so obvious it is showing increased WBC count and inflammatory markers like C-reactive protein probably. The X-ray image is shown below. What anatomical characteristic of the metaphysis makes it susceptible to the above condition? So what is the above condition? What is the condition? What is the condition? The condition is osteomyelitis. Osteomyelitis. This is the condition. The diagnosis is osteomyelitis. And osteomyelitis happens in the metaphysis. Osteomyelitis, it happens in the metaphysis. The question asked is why that is happening in the metaphysis. Among the 4 choices, best thing that suits is small capillary loops that create site for bacterial trapping. Small capillary loops, that's because these are called hairpin bend vessels. Why it is more? Why osteomyelitis happens in metaphysis? The answer is number 1 is called Lexer hypothesis. This is the most accepted hypothesis. Lexer's hypothesis. Metaphyseal vessel appears like a hairpin bend. So bacteria may be caught if they can't negate this bend. And bacteria will lodge here. You see, in diaphysis, the artery is straight. In metaphysis, that's going for a hairpin bend. That's going for a hairpin bend. So that is the reason. This is called Lexer's hypothesis. Another hypothesis is called hobo. This says naturally phagocytic cells are less in metaphysis or deficient in metaphysis. So when bacteria gets lodged in metaphysis, it cannot, phagocytic system won't, because there is no phagocytic cell, so engulfment of the bacteria is not there, so bacteria may flourish very well. So that is called Hobo's hypothesis. Third is called Burroughs hypothesis. This states that metaphysis is a cancellous area. It's a loose bone. So more chance of micro trauma happens. Normal walking, normal jumping, normal running, that causes micro fractures in the metaphysis. Whenever there is a micro fracture, it is microhematoma. Hematoma means blood collection. Blood means blood agar. So bacteria can go very well. Okay. Yes. Right. So these 3 things one should not forget. Now coming to the 10th MCQ. A 9-month-old infant presents with a history of fever and refused to bear weight of the left leg. Later developing a painless limp. Yes, this is the word. Okay, 9 months infant, history of fever, refusal to bear weight, develops a painless limp with appears limb shortening and an unstable gait. Imaging reveals destruction and deformation of the left head. What is this condition most likely? Okay, so it is 9 months. That means he is an infant. And it has a later painless limp, refusal to bear weight in the beginning, and limb shortening. Imaging shows destruction of the head. What could be the probable diagnosis? It is Tom Smith's arthritis. Because Tom Smith arthritis happens exclusively in infants. Infant means less than 12 months. The age is 9 months. So this is a classical presentation of Tom Smith's arthritis. Now you see, usually in an infant below 1 year, transepiphyseal vessels are present in early infancy. Usually what we had read, osteomyelitis happens only in the metaphysis. But to go inside the joint, it has to cross the epiphysis. In an adult, that is not possible because transepiphyseal vessels are not patent, are not present in an adult. But that is present and it is patent in early infancy. So from metaphysis, organism will go into the joint, into the epiphysis. Okay, so that is why I am using a word. Tom Smith arthritis happens exclusively in infant below 12 months. If the child is 2 years, 3 years old, never go for the diagnosis as Tom Smith's arthritis. Okay, so the formation of the growth plate, so organism enters joint through the vessel. Focus usually in a children from, it is septic umbilicus, a gram negative from the septic umbilicus. Most common joint involved is hip joint. As usual, osteomyelitis, books are telling the most common organism is Staphylococcus aureus. Clinically, this condition mimics developmental dysplasia hip or congenital displacement hip. Because what happens is organism goes inside the joint, it erodes, it eats away the whole head. So only acetabulum is there, head is not there. How it will be an unstable hip? Telescopic test will be positive. You will think it is a case of developmental dysplasia hip. Okay, so X-ray shows complete absence of the head. You see here, this side the head is there, this side only half I am able to see, only this neck and half. I am not able to see the head here. Complete absence of the head, complete absence of the head. So this will be the picture. The end result is a hypermobile joint because head is not there. Treatment is, you have to immediately put the early diagnosis is a must, otherwise it will go for permanent disability. Most of the time it will damage the growth plate, will go for permanent disability. When you are very clever enough to pick up in the day 1 or day 2, treat it aggressively with an antibiotic. Arthrotomy means open the joint and clean the joint. That's called debridement. Okay, so the IV antibiotic, arthrotomy and debridement is the only treatment that is available for Tom Smith's arthritis. We'll move on to the 11th question. A 45-year-old male presents with recurrent pain, 45 years, fever, purulent discharge from a sinus tract, okay, of his tibia. So sinus tract is there, purulent discharge means it should be a case of chronic osteomyelitis. After open fracture, radiological imaging shows a bone cavity with thickened cortex. What is the cornerstone of the treatment? That's what's among the 4 choices. Which is the best management? Yes, the answer is sequestrectomy and saucerization. This is the gold standard treatment. Okay, this is the gold standard treatment for chronic osteomyelitis. For chronic osteomyelitis. Okay, chronic osteomyelitis. So chronic osteomyelitis, you see here, I am able to see this is a cavity inside a dead bone. So that is the sequestrum. That is the sequestrum. Okay, you are able to see this area as the sequestrum. Right. Now you see, coming to management of chronic osteomyelitis, treatment of chronic osteomyelitis is essentially surgical. Essentially surgical, only surgery, essentially surgical. 4 important steps. The 4 important steps are radical debridement. You have to go for radical debridement, right? Yes. Number 2, dead space management. Radical debridement means this is called saucerization and sequestrectomy. Dead space management. You are excavating, you are removing the dead bone. So there will be a big cavity. That cavity should be managed. Then overlying soft tissue is very important. Soft tissue coverage. Overall, it should be maintained with antibiotics. You see here, radical debridement is achieved by sequestrectomy and saucerization. Okay, sequestrectomy is removal of the dead bone. There is no doubt. Saucerization, a deep cavity is converted to a shallow cavity. It's converted to a shallow cavity. Conversion of a hollow cavity into a shallow cavity is called saucerization. Removal of the infected non-viable bone is called sequestrectomy. Okay, then what happens, you see here, after radical debridement, defect in the bone and soft tissues are formed. This is called dead space management. Defect in bone, that's called dead space management. The dead space, management, how you will do? You take a bone cement, impregnate that cement, mix the cement with antibiotics. Antibiotic mixed bone cements are available. Fill the space with that. Why I am telling you are doing sequestrectomy or removing the dead piece of bone, so the cavity, the big cavity is there, that part becomes very weak. So that area is more prone for pathological fracture. That area is more prone for pathological fracture. To avoid that, you have to fill that cavity with a bone cement. You have to fill the cavity with a bone cement. Yes. Coming to the soft tissue, the chronic, this is soft tissue is done by plastic surgeon. Antibiotic, staphylococcus, the textbook says IV nafcillin, cefazolin. If it is methicillin resistant staphylococcus aureus, everyone knows it is vancomycin. And the point I want to stress here, this is a very important point, dear friends. You see, antibiotic is given for 4 to 6 weeks. Whenever you want, even after saucerization and sequestrectomy, antibiotic should be given for 4 to 6 weeks. 5 days antibiotics, 7 days antibiotics is useless. 4 to 6 weeks. Okay. In our setup, we are giving minimum 6 weeks. Minimum 6 weeks. Okay. 6 weeks means 1.5 months. 6 weeks means 1.5 months. Okay. 45 days. Alright. You see here, it takes 4 weeks for the revascularization of the bone to happen, by which antibiotic agents are able to infiltrate the site of infection. So you have done a sequestrectomy and saucerization. It takes minimum 4 weeks for the bone to revascularize. Only if it is revascularized, antibiotic can reach that spot. So minimum you should give 4 to 6 weeks. This is a golden point in chronic osteomyelitis. How long will you give antibiotic? Minimum 6 weeks. Register that in your mind. Coming to the 12th question. A 45-year-old man with history of tuberculosis presents with a chronic draining sinus on the left tibia. Radiography image shows multiple bone lesions with areas of necrosis. Given his medical history and radiological finding, what type of sequestrum is most likely? It is tuberculosis, chronic osteomyelitis. What type of sequestrum is the question? Is it tubular? Is it ring? Is it coke? Is it coralliform? What type of sequestrum you expect in tuberculous osteomyelitis? That is the question among the 4 choices. The tuberculous osteomyelitis among the 4 choices, tuberculous osteomyelitis, best answer is coke-like sequestrum. Coke-like sequestrum. Okay, don't worry. We will finish now. You see here, according to shape, if it's a pencil-shaped sequestrum, it's seen in infants. Ring-shaped sequestrum, pin tract infection. Conical sequestrum, amputation stump. Coralliform sequestrum, Perthes disease. Buttonhole sequestrum, radiation. According to consistency, coke-like, coal-tar-like, coke-like sequestrum, tuberculosis. Feathery or flaky sequestrum, tuberculosis. Fine sandy sequestrum, viral osteomyelitis. Coarse sandy sequestrum, tuberculosis. Ivory sequestrum, syphilis. According to color, black or Bombay Niger sequestrum, it's fungal amputation stump. Green color is pseudomonad. One special form is there, kissing sequestrum. So far unasked in any of the Indian entrants, it happens only in one situation, that is peridiscal tuberculosis. Okay, that's all. Whatever book you read, only these much types of sequestrums are there. Please read it once, you will get the answer, no problem. Coming to question number 13. A 10-year-old child presents with localized pain and swelling in the lower limb. Radiographic examination reveals a circumscribed round area of lucency in the metaphysis of the tibia. Metaphysis, that's the clue. Metaphysis of the tibia, surrounded by halo of sclerosis. What's the most likely diagnosis? It is nothing but a metaphysis 13-year-old boy. There is a halo surrounded by sclerosis. It should be Brodie's abscess. Brodie's abscess comes under subacute osteomyelitis. Okay, Gary's osteomyelitis is a diffuse sclerosing osteomyelitis. No cavity. Totally the whole bone is sclerosed. The commonest site, it can happen tibia, it can happen mandible, it can happen in the jawbone. Okay, Brodie's tumor, most common site is upper tibia. You see, exactly, this is the picture. You see here, there is a halo surrounded by a sclerotic rim. And this will happen in metaphysis of the long bone, especially upper end of tibia. Proximal tibia is the most common site. Staph is the most common organism. Common age is second decade. Okay. Now, chronic intermittent pain is the most common symptom. It can happen. It can present with a classical what is called night cries. Okay, night cries. Because a very important cause for night cries is osteoid osteoma. That is why this becomes a very important second differential diagnosis for night cries. Whenever, see, I am giving an additional point to you, dear friends. Whenever a word night cries comes in your exam, think of 4 conditions. Number 1, skeletal tuberculosis. Number 2, Brodie's abscess. Number 3, it is osteoid osteoma. Number 4, it is rotator cuff tear. The word night cries in orthopedic textbook is given only in 4 topics. Number 1, skeletal tuberculosis. Number 2, osteoid osteoma. Number 3, Brodie's abscess. Number 4, it is your rotator cuff tear. Yes. Now coming to treatment of Brodie's abscess, treatment of choice is surgery. Surgery is the treatment of choice. De-roofing and curettage is a standard surgery. It is the standard surgery. Coming to 14th question. A 5-year-old child presents with acute tenderness in the groin, refusing to move the affected leg and appears to have a paralyzed limb. Upon examination, even gentle manipulation causes significant pain. Which of the following condition could be potential cause of this condition? So, this is called pseudo paralysis. This is called pseudo paralysis. Pseudo paralysis is a separate entity in orthopedics. It will mimic like, see, pseudo paralysis. Pseudo paralysis is an entity in orthopedics, dear friends. Focus your attention. Pseudo paralysis means the child won't move the limb because of pain. Paralysis means neurological problem. Here there is no neurological problem. Because of pain, the child won't move that particular limb. That is called pseudo paralysis. Whenever pseudo paralysis comes, the differential diagnosis for pseudo paralysis is number 1, acute osteomyelitis. Number 2, scurvy. Number 3, outdated condition, congenital syphilis. Outdated condition, congenital syphilis. One should not forget pseudo paralysis in these 3 situations. So the right answer is all of the above. Because in acute osteomyelitis, because of pain, okay, periosteum pain, the baby, if they move the limb, it will have a severe pain. So the baby won't move. Scurvy is a condition, you know, it is vitamin C deficiency. There will be subperiosteal hemorrhage. There will be subperiosteal hemorrhage. So scurvy, you know pretty well, bone is insensitive. Bone is not sensitive. Periosteum is very sensitive because it's rich in nerve supply. So whenever there is subperiosteal bleed, it will irritate the periosteum. When the baby moves, severe pain will come. That's why scurvy, there's something called scorbutic rosary, beaded ribs. When you lift the baby will cry like anything, because when you touch the ribs, severe pain will be there, and that's because of subperiosteal bleed. So scurvy is an important cause for pseudo paralysis, and congenital syphilis, it's an outdated condition, but it's a very important cause for pseudo paralysis because syphilis directly causes periostitis, inflammation of the periosteum. When the pseudo paralysis is due to syphilis, this is called parrot paralysis. Parrot paralysis. This is called parrot paralysis. Parrot is name of a person. Parrot's paralysis. Whenever they use the word parrot paralysis, it is pseudo paralysis due to congenital syphilis. Okay? Yes. Now coming to the 15th question. A 10-year-old girl is brought to the hospital with 7-day history of severe pain in her proximal tibia. 7 days. 10-year-old girl, 7 days. accompanied by fever and swelling. Imaging study shows signs of bone infection. Which of the following finding would most likely be observed by end of the first week? Yes, typical INI-CET type of question. End of first week. Yes, what could be the answer? Formation of granulation tissue, development of subperiosteal abscess, presence of sequestra, involucrum formation. End of first week, what will you see in the X-ray? Imaging, X-ray, end of first week. This is a case of osteomyelitis. This is a case of osteomyelitis. End of first week, what will be the only change that is seen in the X-ray? Presence of sequestra. So, it is choice B, 3 only. Presence of sequestra, choice 3 only. You see here, most common organisms, only salient, I am not going to take all the points of Staph aureus, only this slide you focus. Most common organisms, Staph aureus, pus is formed on second or third day, that is not seen in the X-ray. Evidence of bone death, that is called sequestrum. Evidence of bone death is called sequestrum. 1 week, end of 1 week, that's the question. New bone formation, this is called involucrum. This happens end of second week. Okay, and most common site involves metaphysis, that you know, and this is called, in an infant or child, this is called Tom Smith. It can involve the epiphysis also. Okay, so these are the salient points. Okay, so by end of first week you can see the sequestrum. By end of second week you can see the involucrum. That's all I want to insist. Yes. Now we'll move on to the question number 16. A known healed case of tuberculous spine presents with lower limb neurological symptom with bowel and bladder involvement. Okay, lower limb, the paralysis has happened. Known case of TB spine. What can be the most likely cause? This is due to angular kyphosis. This is due to angular kyphosis. What happens in tuberculous spine or pot spine? What happens? Collapse of the vertebra happens. Due to wedge compression fracture, collapse of the vertebra. When the vertebra collapse, you will develop what is called angular kyphosis. You will develop an angular kyphosis that will stretch the nerves and can cause paralysis. Right. Question number 17. An 8-year-old girl presents with complaints of hip pain that has been progressively worsening over the last 6 months. Pains worsening over the last 6 months. She has had a noticeable loss of appetite, weight loss and night sweats. Okay, on examination she exhibits an ontologic gait and the image is shown below. Which stage of this condition does this patient most likely? So the history very clearly says this is a case of tuberculosis, skeletal tuberculosis. Hip pain, loss of appetite, night sweats, all these things says it's a case of skeletal tuberculosis. On examination she exhibits an ontologic gait. An X-ray shown below. Which stage of this condition does this patient most likely related to? So this we all had seen. Okay, this X-ray, you just see this X-ray. Here totally the head is damaged and arthritis has developed. Okay, the joint space is narrowed. So this should be a case of stage 3. Okay, stage 3 is stage of late arthritis. Stage of late arthritis. So we all know this Bobulkar and Ponde's clinico-radiological classification. Stage 1 is stage of synovitis. Here weight loss. Okay, here what happens? There is Faber, flexion, abduction, external rotation, apparent lengthening. Terminal range of movement is restricted only by 25%. Stage of early arthritis, stage 2, stage of early arthritis, flexion, adduction, internal rotation, apparent shortening and gluteal quadriceps muscle wasting, all range of movement restricted by 50%. X-ray shows osteopenia, narrowing of the joint space. Stage 3, stage of late arthritis, significant destruction of the articular cartilage. You see here there is significant destruction of the articular cartilage in this area when you focus. Significant damage of the articular cartilage, and when you see here there is marked flexion, adduction, internal rotation, true shortening, gross restriction of movement, X-ray, subchondral erosion and bony destruction. Stage 4 is the last stage, and that's called stage of pathological dislocation. Totally the hip is dislocated, and what you will get, it will present like a post dislocation hip. And you can see two important things. One is called traveling acetabulum. Number 3, it's called protrusio stabili. You see here, the head is protruding inside the pelvic cavity like this, protrusio stabili. Going to question number 18. Question number 18. A 32-year-old woman with right hip drug susceptible tuberculosis has been treated with first-line anti-tuberculous drugs. That is, HRZE means INH, rifampicin, pyrazinamide, ethambutol for 2 months. She has no longer fever, night sweats, the toxic symptoms settled. What is the next step in management of this patient is the question. Okay, discontinue the therapy, transition to second line drugs, continue INH rifampicin for 4 months, start surgical intervention. Obvious WHO recommendation for 2 months, 4 drugs, INH, rifampicin, pyrazinamide, ethambutol. For another 4 months, 2 drugs, that is continue INH and rifampicin for 4 more months. This is our standard protocol. This is the WHO. You see, first line drugs are INH, rifampicin, ethambutol, streptomycin, pyrazinamide. Second line drugs are thioestosone, PAS, ethionamide, cycloserine. For skeletal tuberculosis, WHO recommends category 1 treatment. That is for 2 months, 4 drugs. For another 4 months, it is 2 drugs. This is very important. It's very important. Okay. So this is very practical question because skeletal tuberculosis is very common in our country. Right. Coming to 19th question. A 25-year-old male has pain and progressive swelling around the proximal part of the left arm. The 25-year-old male has pain and progressive swelling around the proximal part of the left arm for last 3 months. The X-ray shown below, a biopsy reveals small round cell forming pseudo rosette. The age is 25, has pain and progressive swelling on the proximal part of the left arm, 3 months. Biopsy reveals small round cells. Which of the following is not correct regarding diagnosis of the treatment? Diagnosis of this patient. So, what is the diagnosis? This is a case of Ewing's sarcoma. Ewing's. This is a case of Ewing's. The history says this is a case of Ewing's. It is a highly malignant tumor of the bone commonly involving diaphysis. Is true. Okay, the question asked is which is not correct. So, this is true. Bone to bone metastasis is not common. Okay, tumor is highly radiosensitive but prone to recurrence. True. Males are more likely to be affected than females. This is true. Bone to bone metastasis is not common is the exception. Bone to bone metastasis is very common because it spreads in the bone quickly. So this is called pseudo rosette. This is called true rosette. Pseudo rosette means centrally here you see, when you see this is necrosed area. This is the area of necrosis. Necrosis is surrounded by rosette like thing. This is called pseudo rosette. This is called pseudo rosette. Okay. Pseudo rosette means it is Ewing's sarcoma. Pseudo rosette classically seen in 2 tumors, Ewing's sarcoma and neuroblastoma. This in osteogenic sarcoma, you see here, it's like a rosette. There is no, in the center there is no necrotic tissue. So this is called true rosette. This is called true rosette. And whenever a word true rosette comes, it is osteogenic sarcoma. It is osteogenic sarcoma and retinoblastoma. True rosette in osteogenic sarcoma, retinoblastoma. Okay. Pseudo rosette in case of Ewing sarcoma and neuroblastoma. Neuroblastoma. These are all very, very standard NEET PG and INI-CET questions. We'll move on to question number 20. A 15-year-old boy presents with swelling and pain around her left ankle for the past 6 months. The pain is worse at night and unresponsive to analgesics. Pain is worse at night and unresponsive to analgesics. On examination, there is firm, poorly defined tender mass over the distal femur with shiny skin and prominent veins over the swelling. The X-ray is shown below. So obviously a 15-year-old boy, pain worse at night, and tenderness mass over the distal femur, shiny skin, prominent vein, okay, and swelling. The diagnosis should be osteogenic sarcoma. It should be osteogenic sarcoma. Okay, the diagnosis is osteogenic sarcoma. X-ray shown below. Hemopathic cell in the bone marrow, diaphysis of the long bone, metaphysis of the long bone. So your osteogenic sarcoma should arises from the metaphysis. So C should be the right answer. Okay, so you see here, osteogenic sarcoma is the most common non-hematological primary malignant bone tumor. Overall, this is the second common primary malignant bone tumor. So which is the first common primary malignant bone tumor? It is multiple myeloma. It is multiple myeloma. Okay. Yes. It arises from multifactorial mesenchymal tissue. Most common age is 15 to 25. Most common site is distal end of femur and upper end of tibia. That is, most common site is knee joint. Most common site is knee joint, and it's more common in male sex. Classically, it occurs in metaphysis of the long bone. Classically, it occurs in metaphysis of the long bone. Question number 21. A 16-year-old boy presents with persistent pain in his right leg, which is worse at night and relieved by ibuprofen. Pain is more during night, relieved by ibuprofen. Physical examination is unremarkable with no swelling or warmth over the affected area. And X-ray of the right leg is shown below. What is the most likely diagnosis? You see, pain at night relieved by ibuprofen, 16-year-old boy. It should be a case of osteoid osteoma. It should be a case of osteoid osteoma. Okay? Yes. Pain at night relieved by high-dose aspirin or ibuprofen. The diagnosis is osteoid osteoma. Okay? Osteoid osteoma is a benign osteoblastic tumor. Most common age is 10 to 25 years. Most common sex is male. Most common site is upper tibia. It's no malignant potential. The classical histopathological hallmark of that is called nidus. Nidus is a vascular lesion consisting of fibrobascular tissue. This, I will tell you one extra edge point. You see, this is the nidus that is seen inside. This is the cortical bone. This is the medullary bone. Inside that I am seeing a nidus. I will erase everything. You see, this is that nidus in the cut section. You see, nidus is a prostaglandin producing substance. It is rich in nerve endings. It is richly vascular. It produces prostaglandin. Suddenly during night time, it releases prostaglandin, and that is the cause for night craze. That is the cause for night craze. Okay. So nidus, that's the cause of night craze, right? You see here, patient presents with vague intermittent pain, night craze characteristically relieved by high dose aspirin or ibuprofen. Definitive see, coming to imaging, classical X-ray finding small central radiolucent nidus surrounded bony sclerosis like this. CT scan nidus is best identified by 1 mm cut CT scan. You look at this point, this was an asked question, man. Once bone scan, if not picked by simple X-ray, technetium 99 HDP scintigraphy is the best investigation for osteoid osteoma. This is a very, very important question. Okay. So best investigation for osteoid osteoma, technetium 99 HDP scintigraphy, bone scan is there in the choice. That should be the answer. Okay. And the treatment, high dose aspirin till the disease it gets burnt out. The definitive management is complete removal of the nidus. This is the treatment of choice. This is the treatment of choice. Complete removal of the nidus. Okay. Coming to question number 22. An X-ray image shows multiple large chondromas in the hand and feet of a 20-year-old female. Based on this radiographic finding, which of the following statement is false regarding this condition? False regarding this condition. You just read. So this is a case of multiple chondroma, enchondromas, multiple enchondroma, which is otherwise called Olier's disease. It's called Olier's disease. The presence which is false, that's the question. Which is false is the question. Presence of large chondroma may indicate a higher risk of malignant transformation. True. These chondromas can lead to bone expansion and thinning of the cortex, 100% true. Surgical excision of all chondroma is a standard treatment to prevent malignant. This is not possible, that is wrong. If it is in 1 or 2, you can. Whole body is full of chondroma, you can't remove. Patients with multiple chondroma have increased risk of extraskeletal malignancy, 100% true. So this is a case of multiple enchondromatosis. Multiple enchondromatosis is called Ollier's disease. You see here, multiple enchondromatosis is called Ollier's disease. It's called Ollier's disease. When this is associated, when this Ollier's disease is superimposed with hemangiomas, superadded with hemangiomas, that is called Maffucci syndrome. Enchondroma means it is the most common benign bone tumor that is happening in the phalanx, in the fingers, especially ring finger. If one enchondroma happened here, no problem. Multiple enchondromas in all the digits of hand and feet, in the humerus, forearm, everywhere, that is called Ollier's disease. When that is associated with superimposed hemangioma, that is called Maffucci syndrome. For Ollier's disease, you cannot remove everything, and they are at higher risk of malignancy. They are at a higher risk of malignancy. Okay? Yes.